Hello, hi, I'm Selina Luger. I'm a physician at the University of Pennsylvania and a member of the Leukemia and Myeloid Disease program here at the Abramson Cancer Center. And I am excited to tell you about PrE0905, which is a trial of Gilteritinib versus Midostaurin in patients getting induction therapy for AML, and I am the principal investigator of this trial. FLT3 mutated AML has been found to account for about 30% of AML in adults. And what we have found is that, unfortunately, it confers an unfavorable diagnosis to patients with acute myelogenous leukemia. We know that although we can get most of these patients into a remission, the majority of patients will relapse of their disease and subsequently die of their disease. So over the last 5 to 10 years, we have made some advances. First of all, we've identified the FLT3 mutations. We are able to characterize them and know which ones are more and less likely to impact the survival. We have found that giving daunorubicin a dose of 90 milligrams per meter squared during induction improves survival when compared to giving doses of 45 or 60 milligrams per meter squared, particularly in those patients with an ITD mutation in the FLT3 gene. We've also found that patients who get bone marrow transplants, once they're in remission, fare better and have a lower risk of relapse. And more recent data suggests that those who go to transplant without evidence of a mutation do even better than those who go to transplant with residual mutant FLT3 at the time of transplant. And based on the CLGB 10603 study, it was found that adding midostaurin to standard daunorubicin and cytarabine improves the survival of those patients who have FLT3 mutated AML, both the ITD and the D835 mutation, compared to those patients who get chemotherapy without midostaurin. In the last year, Gilteritinib was approved for patients with relapsed and refractory FLT3 mutated AML. It is a FLT3 inhibitor that is potent and able to improve the survival of those patients with relapsed and refractory disease as a single agent. This study is therefore being designed to compare Gilteritinib to midostaurin when added to induction chemotherapy in patients with FLT3 mutated AML to see if we can improve the remission rate, that is mutation negative, in those patients, because we believe that by improving the mutation negative remission rate, we will therefore impact the survival of these patients as well. Now, patients who are seen at your institution may not yet have a diagnosis, and they may not be known to either have or not have the FLT3 mutation. So we also have a screening protocol where you can send samples and need to send samples to our central lab to identify patients who are eligible. We'll go through that again in some detail later. But eligibility includes those patients between the ages of 18 and 65 with any type of FLT3 mutation. We need patients who have normal organ function as defined in the protocol. They do not have to have normal blood counts, as that is part of their disease. We are accepting patients who are not known to have core binding factor leukemia, but if it has not been tested, they are eligible, although those patients who have acute promyelocytic leukemia with or without a FLT3 mutation are not eligible for the trial. As I mentioned earlier, the process for enrolling a patient on the trial includes a screening protocol. When you are doing a bone marrow biopsy on a patient with suspected AML, we have a consent that is signed that is just for screening, and at the time of screening, samples are sent to our central lab. 2 samples need to be sent. One to in vivo scribe, which will be studying the samples to see whether or not they have the presence of a FLT3 mutation. They will also at that time be looking for an NPM1 mutation because we'll be using that as a stratification factor for those who have a FLT3 ITD. At the same time, a second sample is sent to our core facility because they will need baseline samples to be used for later assessment of MRD and for some additional genetic studies that are being done for later analysis. If the patient is found to be FLT3 mutated, then the patient will be eligible to be enrolled. You will have the results of the FLT3 mutation analysis within 48 hours, so that will allow you to treat your patient in an effective and a timely manner based on these study results. This trial is the only trial that will allow you to potentially get Gilteritinib therapy added to induction therapy for patients with AML. Gilteritinib has not yet been approved in the upfront setting. We really would like to improve the survival of our patients with FLT3 mutated AML, and these studies will allow us to do that. This study is being run through Precog, and any site that is interested in participating can contact Precog to be assessed for eligibility. Please feel free to contact them if you're interested in participating.